Hey everyone, my name is Shamar Wilson, and I'm a rising junior at UNC Chapel Hill, currently studying health policy and management at the Gilling School of Global Public Health. Today, we'll be diving into the research that I've conducted this summer at the Duke-Margolis Center for Health Policy, and my research is titled The Consumer is Always Right, a landscape analysis of PROMs, PREMs evaluating healthcare. Before we dive into what a PROM or a PREM is, we're first going to start by defining the rationale behind this study. The rationale all began based on increased interest from multiple stakeholders to identify disparities in care and evaluate healthcare quality through the use of data metrics. And although many metrics are currently in use by patients and providers, such as claims based data or clinical outcome based data, a common complaint among these stakeholders is that these metrics are less meaningful because they lack patient centeredness. A metric that's reported as being more patient centered and more meaningful to patients and providers are patient reported outcomes. A patient-reported outcome can be defined as any report on the status of a patient's health condition that comes directly from the patient without interpretation by a clinician or anyone else. And patient-reported outcomes can be measured in one of two ways: through the use of a patient-reported outcome measure, which we call a PROM, or through the use of a patient-reported experience measure, which we call a PREM. Although both tools are essentially just instruments, single-item measures, or surveys that are collecting patient-reported outcomes, where they differ are the questions that are being asked. Specifically for PROMs, the questions focus a lot more on a patient's perception of their health status and health related quality of life, while PREMs are going to focus a lot more on a patient's experiences and overall interactions with the healthcare process. Because payers are invested in meeting this market demand of patients and providers to find more meaningful measures, this study or this research was conducted to identify how they've done that. More concretely, this research was conducted to identify generic PROM or PREM tools that have been utilized by health plans to hold providers accountable for delivering high quality care and investigate how these measures have been used to identify disparities. We'll now move on to the method section of the presentation. As you can see, this cascading diagram really represents the process that I took as I conducted this literature review. I first started by looking at websites and specifically the manufacturer websites of different PROM-PREM tools to understand how the tool was scored, how many questions the tool consisted of, the question domains of the tool, really just getting an overview of what the tool looked like and how it was used. And after that, I then went to the payer and health plan websites to identify if there was any marks or any like dings on if they have used PROMs or PREMs before. After that, I then did a great literature search, really identifying the nuanced relationships between different payers and PROMs and PRIMs. And then finally, I did a database search on search engines like Google Scholar and PubMed to really identify specific examples of how PROM and PRIM tools have been used by payers to evaluate healthcare quality or identify disparities in care. Before the literature review was conducted, I first started with the inclusion criteria, which focus on generic, non-condition specific PROM or PRIM tools and PROM or PRIM tools that were implemented within the US. PROM and PRIM tools are used quite frequently abroad in places like Europe and Australia. However, I wanted to focus on the US given our unique payer structure. Additionally, although there are not a lot of PROM PRIM tools that are utilized within the US, most PROM PRIM tools that are utilized are condition specific. So that means the questions that are being asked are tailored specifically to a like condition type, and the data that is being collected is can only be applied or I guess like evaluated for that specific population. But given that the research that we're conducting this summer has been focused a lot more on broader populations and looking at greater application, the inclusion criteria was more centralized on generic tools rather than condition specific. In total, I found 6 different tools, and I would love the opportunity to dive into each tool that I found. But given the time constraints of this presentation, we're going to have to only zoom in on a couple of them based on the key findings. But one resource that I've made that should be helpful as we move along is the QR code that you see at the bottom of this first sort of table, which is the PROM-PRIM resource. Here you can find an overview of the different tools that I found, as well as some different links that should be helpful as we move along with the presentation. So we'll now move on to the key findings and recommendation section. The first key finding that I made was that there was minimal generic PROM-PRIM data used in the US by payers to evaluate and reward performance. If you remember what I said, there were 6 different tools that were found, and out of those 6 that were found, 3 were used by payers to evaluate and reward performance. The first is the Medicare Health Outcomes Survey, or the HOS, which was used by the Centers for Medicare and Medicaid Services, or CMS, to evaluate and reward the performance of Medicare Advantage organizations by collecting data from Medicare Advantage beneficiaries. This data that was collected by those stakeholders was essentially turned into a performance score, and that change or alteration in the performance scores would determine the monetary reward for the Medicare Advantage organizations. The next example is the Hospital's Consumers Assessment of Healthcare Providers and Systems, or HCAPS, which was used by CMS to evaluate and reward the performance of acute care hospitals by collecting data from recently discharged Medicare beneficiaries. This data was then translated into a score, and that score then made up a total performance score, and that total performance score was then used to evaluate and reward performance and determine what that monetary reward was. The final example is the Patient Health Questionnaire 9 item, or the PHQ-9, which was used by the Community Health Plan of Washington to evaluate and reward the performance of different clinics based on data collected from safety net patients with a history of depression. And those clinics were awarded based on the change or alteration in the depression score that was calculated from the PHQ-9. One thing I'd like each one of y'all to see is that in this example, PROMs and PREMs have been used on 3 different levels. It's been used on the insurer level, on the hospital level, and on the clinic level. And what's been really interesting to see is that it's been a great way to meet patient and provider demand and also better health outcomes. And for that reason, the primary recommendation here is to increase the use of PROM-PREM data by payers to evaluate and reward performance. However, 2 barriers that present itself to that recommendation are 1, data alignment across payers, and 2, increased administrative burden on providers. Addressing the first barrier, if you utilize that PROM-PREM resource, you can see that there are a bunch of different domains that these PROMs and PREMs are asking, right? So one of the domains could be depression. And then if you look at the sample surveys that we have listed below, you can see each question that's asked and how that question is then funneled into that domain. And what you'll notice is that the questions that fit into domains are very different. So you can have data that's being collected on depression, yet different questions be asked, and this data is not as comparable. So one barrier that payers see is that there's not a lot of alignment on how these data measures are selected. So one strategy to alleviate that barrier is to hold multi-payer convenings to identify those priority areas for alignment on the data metrics, or data measures, excuse me. Another barrier that we see is increased administrative burden on providers. And whether it's claim-based data or clinical outcome-based data or patient-reported data, anytime you're trying to implement a new metric system or measurement system into a provider in their organization, it's going to be met with a lot of resistance because it's going to increase the administrative burden that's faced. So one strategy to alleviate that burden is to increase the amount of national survey vendors. And already by CMS using national survey vendors for both the HCAPS and HOS, which are really reducing the administrative burden that's faced by providers. We'll now move on to the second key finding, which is that there was 3 consumer-facing platforms made from generic PROM-PREM data evaluating performance. This was a key finding that I wasn't expecting to come across, but I think it really ties into the meaningfulness of PROMs and PREMs. The first consumer-facing platform that we have is the Plan Finder tool, which was developed by CMS based on HOS data, and essentially it allowed consumers to compare Medicare Advantage plans. And how it did this was presenting consumers with different stars. They had 0 to 5 stars, and you can compare a plan by seeing, okay, let's see if one plan has 3 stars and one plan has 4 stars, so the difference in stars. Next, we have the Care Compare website, which was also developed by CMS, and this was based on HCAPS data, and it allowed consumers to compare hospitals and home health services, also by using the similar star metric in the previous example. And then finally, we have the Access and Quality to VA Healthcare webpage, which was developed by the VA, and it utilized HCAPS data, and it allowed veterans to compare hospitals and patient experience. Instead of using stars, here the VA used different percentages and bar graph visualizations to allow consumers to make those comparisons. Because consumer-facing platforms have the ability to really create patient buy-in, I think really tie into making more patient-centered and patient-usable data, I think the recommendation here is to increase the development of consumer-facing platforms by US payers. However, one barrier that presents itself is public data reporting requirements. If you notice in the examples, all the previous payers that were listed were public payers, so they're legally required by law to publicly report that data. However, private payers are not. So one strategy to alleviate that barrier would be to utilize the competition-driven market of private payers. Private payers are always trying to find a way to have a value proposition ad or distinguish themselves away from competition. And I think one way of doing that is through developing a consumer-facing platform. And if one private payer were to develop a consumer-facing platform through the use of PROM-PREM experts and user experience experts and be able to demonstrate a high level of patient engagement, that might motivate other payers to enter into that market of developing their own consumer-facing platforms that are based on PROM-PREM data so they can get some more of that market share that the other payer might be acquiring. Next, we'll move on to the last key finding, which is that there was minimal disparities data identified by generic PROM tools used in the US by payers to reward performance. So out of the 6 different tools that I found, 4 were used by payers to identify disparities. And if you look at the sample QR code, you can see that in some of the sample surveys, they're asking questions on race, ethnicity, primary language, sexual orientation, disability status, and that's one method of them collecting that information. But in other examples, they have a sort of backlogging through the EHR system where they're also able to stratify data that way, and that's how they're identifying those disparities. Then if we look at the next segment, we see across the board, academics are utilizing these tools to identify disparities through collecting this disparities data. However, when we look at the last segment, which is identifying how payers have rewarded performance based on the disparities data that's been identified by the PROM tools, there are none that are being used. And this is a problem because when disparities data is utilized to reward performance, we're able to kind of minimize or reduce the disparities that are faced by certain populations and better their health outcomes. So the recommendation here is to increase the disparities data that's generated from generic PROM tools that's then integrated into value-based payment arrangements to reward performance. However, one barrier that presents itself is provider resistance, especially as it relates to absolute benchmarking. So in most VBP arrangements that are looking at disparities intervention, absolute benchmarks are used, which is comparing a provider and organization to another provider and organization without respect to their patient population. So we could have one provider and organization that's servicing patients that are more at risk to experience disparities or are experiencing disparities compared to a population or provider and organization that's servicing a population that is not. And oftentimes the population or the patient and provider that's servicing the population that is more at risk to experiencing disparities can be penalized for that. So one strategy to alleviate that barrier would be to redesign the benchmarks for rewarding performance, really focusing on relative benchmarks. So that's comparing one provider and organization to themselves from year 1 to year 2 to improve our ability to identify how disparities are reduced and not penalize the individuals that are servicing those populations. And that concludes the research I've conducted this summer. You can find my references in the top right corner of that QR code. And I must say, it's been absolutely wonderful being able to conduct this research and learn more ways about how patient voice is included and different decisions that are being made about patient care. I'd like to say thank you to Brianna and Rebecca, who are my mentors. They're extremely helpful as I moved along this process. I would also like to say thank you to the NC team. They're extremely helpful on all the visualizations that you see here within this presentation. And then finally, I'd like to thank you, the audience, for listening to this presentation. Thank you.